Santvana will now speak on calcium, magnesium, and phosphorus. Over to you, Dr. Kohli.
Hello, everyone. I'm Dr. Santvana Kohli from Safdarjung Hospital, and I will be talking to you about the multivalent ions found in the body that are calcium, magnesium, and phosphorus. Now, these multivalent or polyvalent ions found in the body are responsible for many biological and cellular functions. Like all ions of the body, there is a complex interplay of regulation of their levels in the body, of which kidneys play a major role. The GI absorption is balanced by the renal excretion. Whenever the body stores of these ions decline, the GI absorption, bone resorption, and renal tubular reabsorption increases. First, let's look at the major polyvalent ion, that is calcium. Now, calcium is responsible for many biological processes in the body. It is responsible for maintaining cardiac automaticity, the excitation-contractile coupling in the various muscles of the body, myocardial, smooth, and skeletal. It is also a major factor in blood clotting pathways. It is responsible for neuronal conduction, synaptic transmission, and various hormone secretions. It is also a major messenger in mitotic division in the body and a major intracellular messenger for normal cellular functions. It is also a catalyst for various enzymatic actions in the body. Calcium is of particular relevance to the anesthetist because it has effects on the myocardium, maintenance of vascular smooth muscle tone, and blood clotting. The normal total body calcium is anywhere between 1 to 1.2 kilograms. But as we all know, a wide majority of it, that is more than 99%, is located in bones and teeth. The normal plasma concentration of total calcium is 9 to 10.2 milligrams per deciliter, or in SI units, 2.25 to 2.55 millimoles per liter. In the plasma, calcium is found in three forms. The first is ionized free calcium, which is 50% of the total plasma calcium. Now, this ionized free calcium is the physiologically active part, which takes part in all those biological functions. Of the remaining 50%, 40% is bound to proteins in the serum, that is mainly serum albumin. The remaining 10% is bound to the other anions, such as bicarb, citrate, lactate, and sulfate. Intracellularly, the calcium concentration, the total calcium concentration, is as high as the extracellular fluid. However, since the membrane permeability to ionized calcium is very low, the ionized calcium fraction is 1,000 times lower in the intracellular fluid than the extracellular. Now, as we've already seen, that the free ionized component is the physiologically important component of the total calcium. It is maintained in a very narrow range of 1 to 1.25 millimoles per liter. There are various corrective factors and equations available for calculating ionized calcium, but none of them are very accurate. The only accurate way is to measure the ionized fraction directly. There are various factors which can alter the ionized calcium, that is serum albumin, acidosis, gas bubbles present in the blood samples, as well as anticoagulants such as heparin, citrate, and EDTA, which can alter the ionized calcium levels. Let's talk about regulation of calcium in the body. Apart from kidneys and GI absorption, there are three main calciotropic hormones. There are hormones which play a very important part in calcium and phosphate metabolism. The first amongst them is the parathyroid hormone or the parathormone. Now, this is a hormone which is released in response to low serum calcium, and it works to increase the level of calcium in the blood. What it does is it causes increased absorption via the gut, decreased filtration or increased reabsorption in the kidneys, and it also causes resorption from the bone, and it works to increase the serum calcium level. It also increases the activity of the active component of vitamin D. Calcitriol differs slightly from parathormone in that it also causes an increased absorption of calcium and decreased filtration of calcium from the kidneys, but it also promotes bone formation. It does increase the activity of both osteoclasts and osteoblasts, but results in major bone formation, and hence the role in increasing serum calcium is not so much so that increase uptake by the bone. Calcitonin, on the other hand, works entirely opposite to parathormone. There is a negative feedback between serum calcium and calcitonin. Now, this is a polypeptide hormone which is produced by the C cells of thyroid, and it is secreted in response to increased serum calcium, and it works to lower the serum calcium by decreasing intestinal absorption as well as increasing the excretion via the kidneys. Now let us look at abnormalities of calcium levels in the body. Let's first come to hypercalcemia, or increase in serum calcium levels. Now there may be various causes of hypercalcemia, the first and foremost amongst them being hyperparathyroidism. Now, as we've seen that parathormone increases serum calcium, so it remains one of the major causes. Diseases like malignancies, granulomatous diseases, and lymphoproliferative diseases are also an important cause of hypercalcemia. Others include thyrotoxicosis, vitamin D intoxication, thiazide diuretics, immobilization, adrenal insufficiency, and many more. Coming on to features. Mild hypercalcemia is generally asymptomatic and usually incidentally detected on investigations. But severe ones cause very non-specific symptoms and which are widespread over many systems of the body. In the gastrointestinal system, they cause nausea, vomiting, anorexia. Neurologically, they may have lethargy, fatigue, headache, some muscle weakness. There are certain cardiovascular changes which are characteristic, such as hypertension and reduced QTc interval. Then we have renal features like decreased GFR and formation of calcium stones in the kidney. Blood may show increased thrombosis. And there are certain psychiatric issues like anxiety, dementia, and depression, which may accompany severe hypercalcemia. So how do we treat hypercalcemia? The immediate treatment is required in severely hypercalcemic and symptomatic patient, especially if our total serum calcium is more than 3.2 millimoles per liter. The first and foremost treatment is rehydrating the patient with a large volume of isotonic saline. This in itself decreases the serum calcium by 0.5 to 0.75 millimoles per liter. This may be followed by a forced saline diuretic with potent loop diuretics such as furosemide in high doses. This also flushes out calcium from the body via the kidneys. We must at some point also consider ICU and HDU admission if the calcium levels are alarmingly high. Continuous monitorings of cardiovascular status and serum electrolyte concentration is a must. Try to mobilize the patient early because this leads to mobilization of calcium into the bone formation. And first and foremost, try and identify and treat the primary cause of hypercalcemia. Now, if our hypercalcemia was secondary to malignancies or granulomatous diseases or lymphoproliferative diseases, there are other things that can be done. A cancer chemotherapeutic drug called plicamycin, which was previously called mithramycin, can be used in malignancies. A single dose of 25 milligram per kg works well in most patients. If not, then drugs like etidronate, alendronate, and pamidronate can also be used, which promote calcium leaching into the bones. Drugs like glucocorticoids, especially hydrocortisone, also works well in patients with lymphoproliferative diseases and granulomatous diseases. Next, IV phosphates can be given because phosphates usually have an inverse relationship with calcium levels. But since these have their own toxicity, they should only be given when other drugs are contraindicated. Next, we come to lower serum calcium levels or hypocalcemia. Now, this is again when the net efflux of calcium, especially through kidneys, is more than the replacement by intestine, that is GI absorption, or leaching out from the bones. Now, we must also be careful of false low levels of calcium due to hypoalbuminemia. It is the ionized fraction which needs to be low, which is the physiologically active component for it to be labeled hypocalcemia, for it to show features. So ionized hypocalcemia is found in 50 to 60% of ICU patients and in 15 to 20% of new patients admitted to the ICU. Now, there can be certain medical causes, surgical causes, and iatrogenic causes. Medical causes, first and foremost, which is seen in ICU patients, is chronic and acute renal failure, where the serum phosphate levels go up and calcium levels go down. Then vitamin D deficiency, magnesium deficiency, pancreatitis, and hypoparathyroidism are others. Surgically, patients post-parathyroidectomy, post-thyroidectomy, and post-bypass can also show hypocalcemia. Iatrogenic causes include massive blood transfusions, phosphate, citrate, or giving calcium-free albumin, and radiographic contrast, which may have calcium chelators. Now, what features do we see? Now, we don't have a proper threshold level at which the symptoms develop. Usually, hypocalcemia is associated with other electrolyte abnormalities as well. But we know that life-threatening complications occur when the ionized calcium is less than 0.5 millimoles per liter, which the normal level we have seen is around 1.2 to 1.5. Now, the two major clinical effects are neuromuscular hyperexcitability and cardiovascular depression. There are certain signs that we've already learned in our undergraduation that are the Phosphate sign and the Trousseau sign. However, these are not very sensitive, or they may be specific but not very sensitive. At less than 0.8 millimoles per liter of calcium, we start getting the cardiovascular signs. So these are the signs and symptoms which we may see. First is neurological. Since calcium stabilizes the membrane, we may get neuromuscular or neurological hyper-excitability, such as paresthesias, the Phosphate and Trousseau signs, muscle cramps, tetany, and muscle weaknesses. There may be hyperactive reflexes, and in very severe cases, frank convulsions. We may see laryngeal spasm, bronchospasm. In cardiovascular, we may see hypotension, impaired contractility, bradycardia, arrhythmias, digitalis inability, cardiac arrest in very severe cases. ECG shows QT prolongation in contrast to QT shortening, which was seen in hypercalcemia. There may also be psychiatric issues like anxiety, dementia, and depression. Now we come to the classical signs, which are Trousseau and Phosphate sign. In Trousseau sign, we get carpopedal spasms when the blood pressure cuff is inflated above the systolic blood pressure for 3 minutes and sustained. We get a carpopedal spasm. And the Phosphate sign is elicited when we tap over the facial nerve branches as it emerges from the parotid gland. And this results in twitching of the hemifacial muscles. How do we manage hypocalcemia? Very mild degrees of hypocalcemia or even incidental hypocalcemia may be managed with enteral treatment. That is oral calcium supplement of the order of 1 to 4 gram of elemental calcium per day in divided doses. In resistant cases, vitamin D metabolites can be added. But we must always remember to recognize and correct the underlying disorder. If the hypocalcemia is more severe and requires immediate attention, we must correct any coexisting acid-base abnormalities. Administer a bolus dose of 100 to 200 milligrams of elemental calcium over 10 minutes, slow infusion, followed by a maintenance continuous infusion of 1 to 2 milligram per kg per hour of elemental calcium. This is followed by a decrease in the rate to 0.3 to 0.5 milligram per kg per hour. This usually results in a normalization of level within 6 to 12 hours. Again, severe hypocalcemia may sometimes require HD or ICU admissions. Once our levels normalize, enteral maintenance can be started. Now we come to the various calcium preparations that we see. There are many different ones, of which the two are common, that is calcium gluconate and calcium chloride. There is no evidence that any one of them is superior to the other. Both are available in 10% concentrations, and 10 ml of 10% calcium gluconate contains about 9.3 milligram of elemental calcium, and chloride contains 27.2 milligram of elemental calcium, which means that calcium chloride has 3 times the amount of elemental calcium for the same volume as calcium gluconate. This also means that the serum osmolality is 3 times that of calcium gluconate. We must remember that these solutions are high osmolality and are irritant, hence must be diluted, given slowly, and given via a central vein. They must also be given cautiously to patients on digitalis. Now also, cardiovascular and ECG monitoring is required while infusing calcium, and frequent monitoring of electrolyte and creatinine levels. This is the preparations of calcium gluconate and calcium chloride. As we can see, this is 10% calcium gluconate with 0.465 milliequivalent per ml of elemental calcium. This is calcium chloride. This is 13.6 in 10 ml, which means 1.36 milliequivalents calcium per ml, which is 3 times that of calcium gluconate. Now, this is a small diagram showing the ECG changes in hyper and hypocalcemia. Hypercalcemia shows a shortened QT, whereas hypocalcemia shows a longer QT and ST segments. Okay, now we will come to magnesium, which is the other multivalent cation present in the body. Magnesium has been recently studied for its various roles clinically. First and foremost, it is responsible in the body for many enzyme activities for synthesis of DNA, RNA, and proteins. It is responsible for maintenance of proper functioning of sodium-potassium ATPase pump. Now, also it is a physiological antagonist to calcium because it prevents the intake of calcium intracellularly by inhibiting the calcium channels. Now, the widespread clinical uses are there are many widespread clinical uses and are not limited to these. These include preeclampsia and eclampsia, antiarrhythmic, anticonvulsant, bronchodilator, and finds uses in tetanus as well. Like all ions, again, magnesium is very it is regulated by kidneys and GI absorption as well as some hormones. The normal level is 1.5 to 2.5 milliequivalent per liter or 0.7 to 1 millimoles per liter. Now, less than 1% is found in the plasma. So, measuring plasma levels is not an indication of the total body stores. Patients with magnesium deficiency may have normal serum levels as the 99% of magnesium is found intracellularly. We must also use serum and not plasma while analyzing magnesium because citrate and other ions bind magnesium and alter the values which are seen. Now, when magnesium is taken orally, 1/3 is absorbed, majority is absorbed in the small intestine. Now, the balance is maintained between GI absorption and by the kidneys. Even the filtered magnesium by the kidneys, only 1% is excreted. The rest is reabsorbed by the ascending limb of loop of Henle as well as the distal tubule. Now, parathormone increases the magnesium levels in the body by enhancing absorption in the gut as well as enhancing the reabsorption in the loop of Henle and distal tubule. Aldosterone hormone can increase the renal excretion of magnesium. Now, looking at abnormalities in serum magnesium level. The first is hypermagnesemia. Now, usually an increase in dietary intake of magnesium does not cause hypermagnesemia because the kidney has enough potential to excrete it. It is only certain conditions like using antacids and purgatives which contain high quantities of magnesium that may precipitate hypermagnesemia. But by far, the most common cause of hypermagnesemia is iatrogenic magnesium therapy, most likely IV, but sometimes IM, particularly if the patient also has low urine output or coexisting renal failure. Other rare causes include diabetic ketoacidosis and tumor lysis syndrome. Now, what are the features? Initially, there may be non-specific features such as headache, nausea, vomiting, diarrhea, hypotonia, but it progresses to a very specific feature of muscle weakness. Now, hypermagnesemia can lead to significant neuromuscular blockade, causing even respiratory muscle weakness and ultimately respiratory arrest. There may also be cardiovascular features such as hypotension, bradycardia, and ECG may show prolonged AV conduction and widening of the QRS complex. This may lead to severe arrhythmias and arrest. We all know the chart about hypermagnesemia where it progresses from hyporeflexia to prolonged AV conduction to heart block and arrest. Now, the lower table gives us the values in milliequivalents per liter, milligrams per deciliter, as well as millimoles per liter. Now, treatment. The treatment of hypermagnesemia is first preceded by anticipation. While infusing a patient with magnesium or giving it IM, we must always anticipate a risk of toxicity. The signs and symptoms that we learned, that is hyporeflexia, as well as bradypnea or low respiratory rate, should be monitored in patients on magnesium therapy. We must also constantly monitor urine output and KFT levels to see whether magnesium is being adequately excreted out. So patients receiving parenteral magnesium should be frequently monitored, and patients with renal failure or low urine output should not receive magnesium containing medications or should receive a slightly lower dose. If the patient's renal function is normal, just cessation of therapy should be enough if the urine output is adequate, and we can supplement this with giving more fluids and diuretics. This may correct the magnesium levels. However, in patients with low urine output or deranged KFTs, we may require hemodialysis or filtration to remove the excess magnesium of the body. Now, as we have learned that magnesium is a physiological antagonist of calcium, giving calcium gluconate also stabilizes the membrane against arrhythmias, and this may be followed by diuresis or dialysis. Now we come to low magnesium levels or hypomagnesemia. Now, magnesium deficiency is found in about 15% of ward patients and 60% of ICU patients. Now, this is one of the most underdiagnosed electrolyte abnormalities because it does not have features of its own. It usually is associated with other electrolyte abnormalities. Now, this is defined as a serum concentration less than 0.7 millimoles per liter. Now, this usually happens, a nutritional deficiency of magnesium usually happens when there is a poor intake, but there is a prolonged diarrhea or increased NG aspirate or excessive urinary losses. Also, when a patient is on the path to recovery and there is protein formation in the body, then magnesium requirement goes up and a poor nutritional intake may cause hypomagnesemia. So the causes may be a decreased intake due to inappropriate fluids or replacement or malabsorption or dietary deficiency, losses with diuretics, nephrotoxic drugs, a lot of alcohol, small bowel fistulas, diarrhea, excessive nasogastric drainage, some genetic disorders, and redistribution due to massive transfusions, insulin administration, and hyperparathyroidism. So like we said, there are no clinical signs which are specific to hypomagnesemia, but it is associated with other electrolyte abnormalities. It may cause hypocalcemia, hypokalemia, and even hypophosphatemia. It also magnifies the effect of digitalis on the heart. And sometimes with digitalis-induced arrhythmias, even if serum magnesium is normal and we give some infusion of magnesium, it may result in resolution of the arrhythmias. There is also a reactive CNS magnesium deficiency, which shows basically ataxia, slurred speech, excessive salivation, seizures, muscle spasm, and obtundation, which may be attributed to low magnesium levels. So the features include neurological or neuromuscular signs and symptoms, which may be anorexia, nausea, muscle weakness, cramps, lethargy, and weight loss. And later, they may be hyperirritability, hyperexcitability, muscle spasms, stridor, tetany, and ultimate convulsions. A lot of these features can be also seen with hypocalcemia and hypokalemia. So they are all intertwined. Hypertension is common and pulmonary edema can occur. ECG may show prolonged PR and QT intervals, ST depression, and flattening of T waves. And other types of tachyarrhythmias may also occur. Now, since hypocalcemia may be present, we may also see the Troju and Shostak sign. And it is very commonly, as people who have done a lot of ICU have seen, hypomagnesemia is very commonly associated with hypokalemia. Magnesium depletion causes both intra and extracellular depletion of potassium. And sometimes with hypomagnesemia, the hypokalemia is so resistant that even after supplementation of a lot of potassium, the levels are not corrected. And when we realize it was due to hypomagnesemia and correction of magnesium, the results in prompt resolution of hypokalemia as well. How do you treat hypomagnesemia? Now, normally we can give magnesium orally, but the amount required for replacing in hypomagnesemia usually causes diarrhea. So it is only used for maintenance magnesium. IM injections are very painful, which are given during eclampsia and preeclampsia. So they are given in alternate buttocks and deep IM. So it is not preferred. IV route is most widely used. Magnesium is normally supplied in a 50% solution, and each ml contains about 2 millimoles of magnesium. It is usually given by dilution with either dextrose or normal saline and giving a slow IV infusion. However, chronic and severe deficiencies may require a larger amount to be given. This is just a protocol for magnesium deficiency. A lot of ICUs have their own protocols. They may require a 1 milliequivalent per kg for 24 hours and then 0.5 milliequivalent per kg daily for 3 to 5 days. This is in mild or asymptomatic. However, moderate to life-threatening may require higher doses of up to 6 milligrams of magnesium sulfate diluted in normal saline and infusion over 3 to 6 hours. And life-threatening hypomagnesemia, in which the patient is showing features of arrhythmias or seizures, may require 2 grams of magnesium sulfate over a smaller duration of time. However, in renal insufficiency, the doses must be reduced by at least 50%. Now, this is the magnesium preparation, and we can see that it is 50%. It says that it is for intravenous or intramuscular use. The ECG changes seen are in hypomagnesemia, lengthened QT, and again in hypermagnesemia, there may be lengthened QT, but the main feature is prolonged PR interval and QRS widening. The last ion that we come to is phosphorus, which is actually a polyvalent anion or phosphates in the body. Now, again, like with calcium, majority of phosphate stores are in the bone. And again, serum phosphate is less than 1% of the total body store. Now, again, maintenance of phosphate within a normal, narrow range is responsible for many important cellular functions. Energy metabolism, formation of bones as a signal transduction. And as we all know, it is a major component of nucleic acids and phospholipid, in fact, the cell membranes and cell walls. The normal range is 2.5 to 4.5 milligram per deciliter in adults. Like most anions, the maintenance or regulation of levels is a complex interplay between GI absorption, extra transcellular shifts, exchange with bone stores, and renal excretion. And kidneys play a very important role in their regulation. A large quantity of phosphate is filtered by the glomerulus, around 3,700 to 6,100 milligram per day, but only a small amount of it is actually excreted out, that is 600 to 1,500 milligram per day. 75 to 85% of the filtered load is reabsorbed by the renal tubules. Hormones like parathyroid hormone and conditions like metabolic acidosis can cause phosphaturia. As we have seen that parathormone increases serum calcium level and causes phosphaturia, and metabolic acidosis causes phosphaturia because it is a dispensable acid in the body. Now let's look at hypophosphatemia. Now the cause is a transcellular shift, that is shift from the extracellular into the cells. This usually happens when there is protein building and building of muscle mass in the body, that is anabolism, especially with refeeding syndromes and insulin administration. Also, decreased intestinal obstruction and increased renal excretion. There are certain rare genetic diseases which cause a decrease in the level of the co-transporter in the kidneys. Now, mild hypophosphatemia is generally asymptomatic. Levels less than 1.5 cause anorexia, confusion, rhabdomyolysis, because it is responsible for protein synthesis and cell wall and cell membrane synthesis, paralysis, and seizures. Less than 1 milligram per deciliter may cause respiratory depression. Now, mild hypophosphatemia can be corrected with oral supplementation, but severe require IV repletion. There are many oral replacement products available, such as K-Phos neutral, phosphosoda, sodium phosphates. So it depends on the kind of ion that we want to give along with it. Now, the IV replacement also has two products, that is sodium phosphates and potassium phosphates. Again, the content of phosphate is nearly equal in both, but it is the cation that we want to give. And sodium phosphates also have a higher osmolality. So these are the sodium phosphates and the potassium phosphates that are available for IV infusion. This is a synopsis or a so phosphate is 2.5 to 4.5, which is a normal range. So there is a concern in refeeding syndrome where insulin, when it is released, phosphate shifts inside the cells. Phosphate is also lost in patients with undergoing CRRT. When a patient has CKD or AKI, the phosphate levels go up and calcium go down. But on continuous CRRT, the patients sometimes require phosphate replacement as it is filtered out during CRRT. So these are the preparations, both oral and intravenous. Coming on to hyperphosphatemia. Hyperphosphatemia or increased phosphate level is seen in patients with acute and chronic kidney injury where calcium falls and phosphate increases. It is also seen in many bowel purgatives which contain a high concentration of phosphate. It is used in preparation for colonoscopy. It may even cause acute phosphate nephropathy. Now, increased phosphate in the body leads to increased parathormone production. It also causes production of vitamin D, which causes absorption into the bone and hence decrease in the serum levels. Now, the main feature is increased cardiovascular morbidity and mortality. The treatment is oral phosphate binders, which block absorption into the gut. And as we've all seen in the ICUs, where a lot of CKD patients are present, we give sevelamer, which is a non-calcium phosphate binder. So we have calcium-based phosphate binders and we have non-calcium-based, which may be metal-based or resin-based. And sevelamer is one of them, which is resin-based, and it comes in tablets and sachets, which may decrease the binding of phosphate, in which it binds to the phosphate and decreases its absorption into the gut. Thank you. This was about the 3 multivalent ions of the body. I hope this was useful. I will be open to questions now.
Unmute, ma'am, please. Please unmute.
Thank you, Santvana, for covering the topic so well. Very beautiful slides, and you very nicely and comprehensively covered up the major cations. One word of advice for the postgraduates. These are topics which you really have to read over and over again because it's a very theory-based lecture, both of them. And I'm sure you would be getting the recordings of the proceedings. Both the speakers have done more than full justice to the topics given to them. And I hope all the residents really benefit out of it. All the best to the postgraduates for the forthcoming exams. And I now hand over to the organizers. Thank you very much.
Thank you. Thank you, everyone. Thank you.
Thank you, ma'am. Thank you for giving your inputs for APPEC2023, and thanks to both the